I will give you some sort of my interpretation of the situation of the healthcare AI applicability as I have interpreted, and then because most of it is still on a clinical level, and then I will sort of give you my journey, a review of my journey when it comes to digging down to management AI or management research by use of AI. So first, state of art and state of practice is almost the same in the medical domain as I see it, because it's a very premature stakeholder. They are sort of not. I mean, they could use a lot of technologies like optimization, simulation, machine learning, and what is the core base of AI. But still, they don't use it that much as you could hope. As for example, if you compare to the finance authorities or transportation section, how to plan the flights and the crews and the trains and etc. But still, they are sort of in a premature state, I would say. But now, if you see the different research calls that are out there now, we could see that there are calls directed to AI in healthcare and the applicability of such methods. So if I first go through what I have seen is in the medical decision making, we can have. I have divided it into prevention, diagnosis, and therapy. And prevention is, as for example, could be risk assessment, as if you collect, you extract data from patient journals, and then you have the sort of preconditions of something, and then you have some therapy or some intervention or anything, and then after that you collect data to see what happens. So you have a supervised learning and could draw or extract information based on that to see what features are actually the most important in order to get this disease or to be free from the disease, whatever. Another thing that I actually is that I'm involved in, sort of in my department at BTH, is the behavior that you can actually try to foresee the behavior of, as for example, the elderly people in elderly care, dementia people. So it's actually interesting because when it comes to the new law, the GDPR, and we would like to foresee or predict how the behavior of a citizen or the people in the residence could actually lead to insight how your mentally or your health status will decrease or change somehow, and the sensors and the information that we have at the moment is the power consumption data, and it's not as intrusive as for example if you monitor with cameras or other data, and we actually got some interesting results based on that. But still, it's a challenge when it comes to the privacy aspects. Diagnosis, of course, it's well known, as for example cancer, image processing, where you have all kinds of learning, deep learning methods, try to analyze and investigate if you have some sort of cancer evolving. We have triage. That means how you sort of your path through the healthcare system, based on some sort of pre-condition or pre-diagnosis. This is at the moment mostly based on expert system, you could say, that is not that has no learning abilities. That is kind of a experts, medical experts that have sort of stated the rules for what path the patient would actually take based on some information, some features. And then we have therapy, and it's radiation, how as for example you would treat with radiation a cancer or whatever, in order to optimize, not to give the parts in your body the radiation that is not supposed to have it. So this is sort of just a short review of what I've seen in the medical decision supports. When it comes to state of art and state of practice, it's almost the same. And it's actually because of the premature stakeholder, I would say, and also we have this legal part. We need ethical approval of to continue or to pursue the research on private data or intrusive data. So, and from that, I will sort of leave this sort of because I accidentally was involved in a project a couple of years ago at the university hospital here in Stockholm, and they asked me to give them a help on how to analyze processes within managing orthopedic patients. They had a problem. They have had an hypothesis that we can't handle this kind of patients because we don't know how to deal with them. We have long waiting times, and that is not very beneficial for the outcome of the intervention. So they would like to have some sort of view of what is actually happening here. So I will just give you this journey now so that you can sort of understand what led to the other. So we were having a lot of meetings, and we were discussing how the distribution of patients looked like for this specific patient group that they were interested in. And we built a simulation model, simulation as if it's a computer system that sort of simulate what is actually happening on a high level. We got some sort of arrival pattern. We had a lot of interviews with the experts, both administrative experts and clinicians. And this is a sort of view of the path for the patients. And from that, we could see that we have non-hip fracture patients. It was non-elective patients. It is kind of emergency patients, you could say. It's not that emergent as if you get a shot or whatever, but it's still non-elective, so it has to be treated within a certain time frame. And we could see that the hip fracture patients had a higher priority, and they were treated within 20 hours, and the rest were treated basically within 40 hours. And this was not very appealing to the medical experts. So we were sort of thinking, what could the reason be? Could it be the time from the point when they entered the emergency care to the point when they actually were given a surgery intervention? Sorry, from the time when they entered this emergency care to the time when they actually were diagnosed and decided on what kind of treatment or intervention they would undergo. we collected a lot of data to see what was actually the bottleneck in this process, and we found out that it was actually the OR, the operating room department, that was actually the bottleneck of this process. So in the following up meetings, our hypothesis was that we had the OR department was sort of the failing link here, and we analyzed the way of working there, and we based on that that led to that we understood that the time from one surgery was finished to until the next one was conducted. It took a very long time, and much longer than they actually thought. So based on that, we saw that if I just oh, thank you, Steve Jobs. Well, it should be a rectangle here. If we just simplify this process, it's a surgical procedure, and this is the pre-state where you sort of give the anesthesia and prepare the patients. This is the knife time, it is a translation. It's a strict translation. It's where the surgeon actually do his job, and the last part is where you put the anesthesia out and so on. So that is the simplified surgery. We could see that the turnover time between two surgeries was actually measured to be approximately 2 hours for these kind of people. And 2 hours, meaning you have approximately 1 hour in the beginning in the morning, 2 hours in the middle, and 1 hour in the end. And after that, the time went approximately 2 in the afternoon, and it was too late to start with the next one, meaning that the surgeon was actually in progress in doing his or her job here and only here, and was failed to do anything else at the rest of the time. So how could we improve that? So first of all, turnover time. It's a time between two surgery. It was this time from the knife out and the knife in. It took 2 hours, and we were trying to decrease that time. How could we do that? How should they actually do it? Because we had succeeded to find what is actually the failure here. What is the bottleneck? 2 surgeries a day for one surgeon is too few. It's absolutely too few, and of course it depends on how long the surgery is. But in this case, it was too few surgeons, and it's too less production in this environment. So we did in the simulation. We started to, in order to get that information, we first, in the simulation models that I described, we added an extra operating room. We said that, okay, we imagine we have another team, another operating room, and another team working in that operating room to be able to take care of the emergency orthopedic patients. How would that affect the waiting time? This is before the intervention, and this is after. So we could see it certainly did something with the waiting time, and that in end would affect the clinical outcome for the patients. And we were really fine with that. But open up another operating room, having another team consisting of anesthesia nurses, anesthesia doctors, other nurses, approximately 3.5 persons. It would cost a lot of money. So based on the 2 hours turnover time, our hypothesis is that we could decrease that time with only 20 minutes. And all the experts working at the unit here, they thought, and their hypothesis was that it is manageable. So we decreased in the simulation model the turnover time by 20 minutes, and we got almost the same results. So how could we decrease that turnover time? How should they work faster? Should we use more resources, as in the first case? Or could we find some way of working smarter? And that led to another way of looking at the problem. If we could use some parallel workflows or parallel processing, if we, before one surgery is actually closed, could start with the next one, so that we can decrease this turnover time. That means that we have another team that has to start with the upcoming surgery before this is closed. We have to think of that this is one operating room and one surgeon, or two maybe, but it's the same room. So we will maximize the utilization of the surgeon or surgeons, and we will maximize the number of surgeries that we can sort of put into this in this operating room. Okay, that needs another team that start with this surgery. And if we have 2 operating rooms, and instead of 2 teams working at each of the operating, we could have 3 teams, sort of, what it's called, when you when you go to the one operating room, start with this one, and then you're helping out with the next operating room. This is no-brainer. This is not rocket science. You could do that yourself. You can schedule surgeries, and you can schedule your teams in order to make them work like this, so that the turnover time will not happen at the same time, of course. But what happens if we scale this up? We have 3 operating rooms, and we would like to use 4 teams. We have 1 operating team working here, another one here, and another one here. And we'll have 1 extra resource, as in a team, operating team, helping out with this, when they kind of start off with the upcoming surgery. So that means that we want to fill this day. This is, if you imagine this is a day with a lot of surgery that has to be scheduled, but we have limited resources. So this gray field here, we have 4 surgery teams are working, and that we can't have more. So we can't have a lot of turnover times at the same time, and then it becomes kind of difficult for the human brain to calculate in Excel. So you have to come up with some sort of optimization model to do that. And then we solved it, and it turned out to be really great, actually. There is a lot of things to do. The clinicians want specific surgeons or surgeries to take place in different times in day, based on preferences, based on what kind of patient it is, and also what is the probability of how long this procedure will take. And now it comes to how can we estimate how long this procedure will take, and it will require a lot of data analysis, of course. We have started to work on it, but it's still in its, it's very, it's not that we have an accuracy of maybe 65%, but it's still too small to see to really use. But we have limited amount of data, so we need more data in order to see what we can come up with. So what I'm actually saying here is that if we have 4 teams and we can manage more surgeries, we want to be cost efficient. We have to use the resources that we have in the healthcare much better than we do because of the challenges, as you all are aware of. But when do we reach the ceiling? When is the break point for? I mean, I could have 6 resources or teams here, and then, but what does that cost? So we want to find some sort of measurement of how the performance of this unit actually works. And so I was thinking, or we were thinking that what if this is a enterprise or an industry that actually wants to sell something, what is it that they want to sell? I was suggesting that they actually sell the surgery time, when the surgeon or surgeons actually is there and do his or her work. And the rest of the time is actually it's how you manage or facilitate, or how you organize your resources at the operating room department, how they work, how they manage, or how they perform in order to sell as much surgery time as possible. So I think, I will test this with you, I think that if we could find some sort of key performance indicator that actually says that the number of surgery time, or the amount of surgery time as a ratio of how much labor time your utilization is from the operating room department, is actually an indication of how you perform. And this is so this is basics. If you come to the other business, if you look into the hotel section, for example, how many hotel rooms can you clean or rent out or whatever? It's but in this case, it's so they are just facing day-to-day challenges, how to manage all the people that they meet. It's so difficult for them to think in those terms as I just suggest now, to see how actually are you using your resources. So if we could sort of measure the time spent on an operating room, just to sum up all the resources that are working here, and divide that with how much surgery time you are selling, or on vice versa. It doesn't matter. It's the relation that I'm of these two measurements that I'm interested in. Then we have some sort of indication of how are your unit performing. But then you can say, okay, but what happens if we have very time-consuming patients, or patients that have long surgery time and doesn't have this time-consuming requirements? Well, we have to dig further into that. We have to find some sort of we have to normalize this performance indicator in order to meet, as for example, how many surgeries we are doing, what kind of surgeries it is, so that we can actually compare the performance with other units, not only with ourselves. And this is totally new for the healthcare. And in this example, I sort of mix, as you see, optimization techniques, machine learning, and simulation. I have a mixture of these techniques in order to find decisions on how to plan and schedule your resources. I will set up an experiment with real data. I will. This is in work in progress. I will look into sequential workflow, as if you have, the surgeries one after another, and then if you could work in parallel, as I suggest, and as we actually are trying at this hospital in Stockholm today. But the challenges are mostly how all the people working at the unit are going to adapt to this new way of working. But they are so inspiring to work with because they are really interesting. They all understand the challenge of this, and this is really awesome to work with applied science and research. It's really awesome. I will look into 4 weeks period of time. I will use 3 operating rooms, and I will do this performance measurement to evaluate how it works. Well, actually, this is. I think this is it. Yeah. So the 3 techniques that I told you about is it's a mixture of the 3 of them, and I think it's. I haven't met any. I mean, the research in surgery planning or scheduling and workforce planning is of course is a community that are a lot of research in, but that if you look into what is actually happening in the hospital today, it's really in a very premature state. So to me, it's really fun and challenging to dig into this area. Thank you for listening.